Hello, I'm Dr. R.D. Khare, Pediatrician from Mumbai. Today we will revise our knowledge about the cerebrospinal fluid, the CSF, the indications for examining CSF and its interpretation. Before we do that, we'll have a word about lumbar puncture. We all know that before doing a lumbar puncture, we must rule out raised intracranial pressure. And for that clinical assessment in the form of abnormal breathing or irregular pupils or palsy of either fourth or sixth nerve is not an adequate ground. That means the coning has already taken place. So if you are seriously suspecting that there is raised intracranial pressure and therefore CSF may or may not be done, then MRI is the only answer. If it shows that there is brain edema or the tonsils are already lying low or the space around the cerebellum is narrow, then we should hold on the lumbar puncture. There is nothing like guarded lumbar puncture. It may result in coning. Now we go to the indications and interpretation of cerebral. Now we do the CSF examination most commonly in infections. So we have some categories. They will be infections and then seizure disorders, and we will see whether in a seizure disorder we really need to do a lumbar puncture, if at all when. Then we will consider other group of disorders where we may think that the CSF may not be very informative, like the immunological disorders and the metabolic disorders and also some of the mitochondrial diseases. So we'll try to cover up that, and perhaps we will focus not so much on cell, protein and sugar, because this is commonly what we see. But I thought what is outside that may also give us a good information about what the likely cause is. Of course, no need to say that ultimately clinical diagnosis is the main thing, and imaging has many times confirmed the diagnosis without even some degree of CSF. But today we are going to concentrate on CSF, and we will give less importance to imaging and to a certain extent immutable disorders. So we will have CSF interpretation and see whether we can do it to a reasonable extent. Infections. Acute bacterial infection is one of the commonest indication for examining CSF, and you know that there are increased number of cells, maybe even thousands, 10,000. Most of them are neutrophils. The sugar is low and the proteins are high. But we are going to concentrate beyond that. We are going to see whether on the gram scale there are any organisms and whether the culture gives us a lead about a type of organism. So while we have the immediate information about the cell, sugar and proteins, which we all know for the last so many years, we will concentrate on the other category. Are there any other criteria or avenues for information besides this? So we saw about the acute bacterial infection. Yeah, and also we have made a diagnosis, do a lumbar puncture. Now what about a lumbar puncture second time, repeat lumbar puncture, to see the course of illness? Once you have documented an abnormal CSF, it is important that you show a normal CSF, or at least in a chronic meningitis, resolving inflammation or infection. Therefore, if let us consider the bacterial meningitis, if the patient is improving, you can wait for some time, and when the CSF, when the clinical picture is more or less normal, you may do a lumbar puncture once to see that there is a declining trend, or you may do a lumbar puncture right in the end to show that everything, because there is no hurry of doing a lumbar puncture because the patient is improving, and therefore you don't want to do lumbar puncture 3 times. So once in the beginning and maybe once in the end when you know that a repeat lumbar puncture is likely to give almost certainly a normal report. When do you repeat? When you don't find a rapid motility. Within 48 to 72 hours, if there is no clinical improvement, what I mean is in fever and in neurological picture, or maybe a worsening, though fever may be not a very picture, worsening neurological picture, I would like to consider a repeat lumbar puncture. And not to forget here also, not only we concentrate on sugar and protein, but try and see whether we can isolate organisms. Maybe on smear, it's important to diagnose with smear. Culture, and of course the gene diagnosis and PCR. This is one thing which is available to us nowadays, and we should take the advantage whenever possible of the PCR. So this is one point that we'll always remember about repeat lumbar puncture, especially in the case of acute bacterial meningitis. We come to chronic bacterial infection, and in that tuberculosis is the most common thing that we know, and in that the cells may be raised but not as much as in bacterial meningitis. The proteins also may be raised, so it is the same thing but to a lesser extent, and the cells predominant may be lymphocyte. The sugar is decreased but not to the extent of that we see in acute bacterial meningitis. And the third thing which we know is CSF apart from this, and there the gene expert comes into play. And gene expert is one thing, or the PCR diagnosis of tubercular bacteria in the CSF, and of course culture, but culture will take a long time of 6 weeks or so. So I think we will concentrate on demonstrating gene expert and also showing the PCR of tubercle bacilli for immediate and a reliable diagnosis of tubercle. So this is what is outside our routine cell protein and sugar which we know for so many days. We will consider now little more about bacterial meningitis. Often we may have a situation where the patient has come to you after having taken some treatment, and therefore partially treated bacterial meningitis may produce some problem, not really very many. But he has treated significant treatment outside, then the cells may go down a little bit. Maybe they will shift from polymorpho to little mononuclear cell. The sugar will continue to be low, may not be as much, and the proteins may be raised, but so everything but little less than what you said, and the organisms may not be grown, or because of the treatment we may not see the organism. So partially treated acute bacterial meningitis may produce some problem. One thing which we should know about the acute bacterial meningitis and tuberculous meningitis, which we often overlook, is lactate. CSF lactate is raised in acute bacterial meningitis and tuberculous meningitis, and how it is useful is something we are going to see immediately now. Viral meningoencephalitis. Okay, the cells may be raised, usually not so many, but in certain types of meningitis they may be as high as even up to 1,000. Many of them are likely to be mononuclear cells. Proteins may be raised in that also, but we concentrate on sugar, that in bacterial and chronic bacterial meningitis and tuberculosis, while the sugar is relatively reduced, in viral meningitis sugar is normal. So sugar is something on which we sit. But the point that we wanted to make, that while in acute bacterial meningitis and tuberculous meningitis the lactate is elevated, in viral meningitis the lactate is normal. So here is a case again for studying lactate in CSF. And in addition, we may be able to diagnose some DNA or something, some antigenic diagnosis on CSF. For example, we have herpes simplex meningitis in a newborn baby, then you may be able to make that diagnosis depending upon the antigen or the gene diagnosis. So we concentrate beyond sugar, protein and cells. So we have seen acute meningitis, partially treated bacterial meningitis, we have seen viral also. Then we may go to brain abscess, but it is not very much different, but it's more confusing. Of course, the diagnosis is very clear on imaging, but the cells may be not very high, the protein may not be very high, and the picture may be relatively confusing. The sugar may or may not be normal, but this is something which we need to know, that it's like a partially treated meningitis, the CSF may be confusing. So while we have seen all the common infections, we will also consider perhaps a fungal meningitis, relatively uncommon. There also the cells may be increased, the sugar may or may not be normal, the proteins are usually elevated, and you may be able to show some cryptococcus or something on the CSF if it is a cryptococcal meningitis, or some fungal, maybe some budding fungus may be seen on CSF. So we make an effort to see whether there is a fungal meningitis also. And in that, in cryptococcal, as I said, the cryptococci or some budding of the CSF. So we have considered a common variety of infections of the CNS. Now we go to inflammations of CNS which are not infections. And the two things that we would like to see are, number one, the child has some illness and he has a neurological illness, and the CSF shows that the cells may be raised, proteins may be mildly raised, the sugar is essentially normal, but what is more important is significant amount of lactic acid and a significantly deteriorating course of neurological event. What it could be? MELAS, lactic acidosis, and there we have significant increase in the lactic acid and also a downward course of neurology. So we think MELAS is important. MELAS can occur in any place where there is anoxia of the cerebral tissue, because in anoxia the alternative pathway of metabolism is taking place and then lactic acid accumulates. So anoxia, hemorrhage, or some such thing where lactic acid is likely to accumulate, and MELAS is one thing that we will consider. Another category where the CSF may show something different, and that is cells may be mildly increased, sugar is essentially normal and proteins are increased, cell sugar normal, or what it can be. Especially I am doing it in the second week of the illness. Oh, it could be GPS, increased amount of protein in the CSF, especially in the second week, and the cells and all is normal. It's an important diagnostic. Nowadays we have other diagnostic tools, but increased amount of proteins in GBS along with the neurological picture of multiple polyneuritis is likely a more or less confirmation of GBS. Then we may consider some of the other diseases, like for example mitochondrial diseases. You know that mitochondria is a very important structure for cellular metabolism, and therefore mitochondrial diseases are something where, though they are not infections, a CSF examination will give a lot of information. And mitochondrial encephalopathy is something which we should keep in mind, and this is a place where lactic acids are increased in a considerable amount, and therefore we consider this. So now we are giving importance to lactic acid, which we may not have given all these days. So mitochondrial encephalopathy and CSF lactic acid is something which we see, like just now we saw the MELAS. And then the other varieties which may be there, for example aminoacidopathies. In aminoacidopathies also, let us consider one variety, non-ketogenic hyperglycinemia, not hyperglycemia. Increased amount of glycine in the CSF, it gives us to very bad neurological picture in an infant who does not have any perinatal problem, and there is progressive deterioration. Treatment may not be helpful in every case, but the glycines are increased significantly in the CSF, and there is non-ketogenic hyperglycinemia. So these are some of the examples of what we see abnormality on CSF, and the point that we have understood here is, while the cell, protein and the differentiation of cell between polymorphs and nucleosides are also important, let us not forget the sugar, the proteins, the type of proteins, and something beyond that. For example, DNA availability, immunoglobulins, culture facilities like in tuberculosis, and lactate, which we had forgotten all these days. Increased amount of lactate, good point to differentiate between viral and bacterial, and as I told you, some of the lactic acid. Whenever there is asphyxia, hemorrhage, anoxia, the lactic acid in the CSF is likely. I think this is something which we now keep in mind when we interpret the CSF. Thank you very much.